Okay, everybody. Let's get this ball rolling. Okay, I'd like to call this meeting of the Health and Human Services Committee to order. Representative Hawkins, you look like you're the only presenter here. I don't see Penny Houston, Representative Houston, and Representative Newton is not here. So until they come, you get to be first. And really? Okay, I guess so. Okay. All right, this is House Bill 1276. And that is LC 338988. Does everybody have it in their folder? Everybody got it? And the right one. Okay, you have the floor.
Thank you, Madam Chairman. You know, over the years, I've been down here since the 90s with the testifying on healthcare bills. We've always had a problem with understanding what insurance does and what it doesn't do, what it pays and what it doesn't pay, what procedures are covered, especially with CMS, well, Medicaid in the state of Georgia. And so this is a stab at trying to clarify some of that. Also, without getting into contracts, for years, we've tried to get contracts and they'd say, oh, it's listed on the internet, but it wouldn't be a signed dated piece of paper. So that's didn't look like a contract to me. So Mr. Wethington and I have got together and worked on this over the summer. I give him credit for what you see in this bill. He has come a long way to help put this information on the DCH website. It's the information that we've always wanted to see without getting into a thick contract. This information will be changed or updated biannually. These are the examples starting on line 24, the number and type of providers around this state, county level data, information, hospitalization, utilization, and cost, readmissions rates for hospitals, emergency departments, utilization information, paid by facility. You'll notice on line 31, membership and beneficiary enrollment data due to demographics and population. Line 33, data on prescription drugs, volume of such medications of the 10 most costly drugs, generic versus name brand. Excuse me, on line 37, it speaks to including per member per cost figures. That's something we've always wanted to get and look at. And this is not an accusation of anyone doing anything wrong. This is purely, if we're going to make things better and advance the availability of healthcare in this state, we got to know where the problems are. Just like in healthcare, when a patient comes in, we do a differential diagnosis. We figure out what's wrong, and then we know how to fix it. Well, for all these years, we've had a hard time understanding exactly what's wrong. So this is going to go a long way for us in the future to address the problems we've seen in rural healthcare, even in urban healthcare. I'll hush up, and if there are any questions, be glad to have them.
Questions from the members? Everybody seems to be reading carefully.
Yeah.
Oh, Representative Hutchinson.
Thank you, Madam Chair. Does this require administrative costs to be listed?
No.
No.
No, this information is actually going to be contributed by the groups that Jesse Withington supports or represents. It'll be electronically filed on DCH and then updated every 6 months.
Okay.
So there's not a fiscal note associated with this.
No, that's not what I was asking.
Oh,
I was asking because I'm concerned with a lot of these plans and how much they're spending in administrative costs, like for regulation. I suspect that particularly in mental health, we're spending a whole lot more in administration than we should. And I think there's probably a way to make it more streamlined and put more of that money into services? Would this help that?
Representative Hutchins, I think you will find that with the passage, and I hate the number that on this one, 1013 bill, the large mental health bill. I don't know how that happened, but if it was planned, I'd
Seems
like
like
to object to it and call the 1013 plan. Maybe we can call it something. We'll just name it tomorrow. Come up with another name for it and we'll just do away with the 1013. There is a point in there where we will be requiring proof of how much they're actually spending on taking care of patients, and that will give you the information. We've also worked and talked to Jesse about it. It's not finalized how much. I think Florida has 95%, which I think it does, which it requires to be spent.
As a medical loss ratio?
Yes.
That sounds a little high for Florida, but I need to check, ma'am.
Now, I think okay, they may have it wrong, but I think the numbers I'm thinking that some of the around us have a little bit lower.
Right, states can set the MLR.
Right,
It is.
and I think we're at 85 right now, which isn't being verified, and
That's right.
I think some state around us has 80 something, but there are also some 87, the 90 range. So that has yet to be set. Okay. Other questions for the presenters? Okay, what's the desire of the committee? Have a motion do pass? Do I have a second? All right, I have a motion and a second. Do we have anybody who wants to speak on that bill? No, we don't have anybody. There's no one that's signed up. Did anybody come in late and want to speak on this bill? Okay, we don't have anybody. Anybody else have any? We have a motion do pass in a second. Do any of the legislators have anything they want to ask? No? Oh, wait a minute, three. Who's three? That was, okay. All right. Everyone in favor of House Bill HB 1276, say aye.
Aye.
Anyone opposed, say nay. All right, the ayes have it. Thank you very much. Okay. Okay. Welcome, Representative Houston. How about you going next? Let's do 1186, the speech pathology and language and the audiologist bill. Is it in here? Yeah, I got it. This is House Bill 1186, LC 49082-8S. Everybody got it? LC 49082-8S. Okay. You have the floor, Representative Houston. Have you been to the Health Committee before?
No, after all these years, I've never been. I've had several bills about hearing aids and things, but they didn't go to hell.
They didn't go to health.
They
Okay, well,
didn't
we're
go to
glad to
health.
have you.
But thank you. It's good to be here and thank y'all for the job y'all do. And we, Representative Newton and I just had to run over from Ways and Means. So if I have to catch my breath, he was going mighty fast.
Oh, okay. So that's where you were.
That's where I've been. Today I'm bringing you, did we call it the LC number? Did you call that?
I
out?
did. Oh,
Thank
let me
you.
do it again. LC 49082-8S.
Well, House Bill 1186 is a proposal that the Georgia Audiologist Advisory Committee proposal to revise the statute that it allows trained personnel to perform hearing screens on children from birth to 22 years of age. Previously, the law did not allow trained personnel to do hearing screens on children that were older than 3 months. And this changes it. And I have a letter from we have the support of Public Health. And I have a letter from Dr. Toomey for you to review. And she says that this bill would better identify children with hearing losses who are unable to complete traditional pure tone hearing screens. And I also have another letter from the audiologists, the Georgia Academy for Audiologists, and they feel like that Georgia children with hearing losses are fortunate to have this organization, which they refer to as the Georgia Education Advisory Committees, advocating for the needs of Georgia children. And I'll be glad to take any questions. We're just changing the age. And these will be trained personnel. One thing that you probably run into in your schools, if previously, if a child in school had a hearing, the teacher felt had a hearing problem, they would have to be tested by an audiologist. And this way you can have the trained nurses can test them. And I don't know if any of you've had your hearing tested lately. It's nothing that goes in your ear. They just put those little earphones on it. You mash your button. It's really no judgment call. It's just a routine thing. And we test children when they're born, but so many times they're not being followed up on because of we just do not have that many audiologists in the state. We did get a mobile audiology unit that goes all over Georgia testing children, but you know that if a child can't hear when they go to school, they're gonna get behind. And I'd appreciate your support.
Okay, questions for the legislator? We have anybody? Oh, who's it? Bennett, Representative Bennett.
Thank you, Madam Chair. Representative, I just would like to thank you for bringing this bill before us. It improves access and availability for K through 12 children to be able to receive this much needed hearing service. So anything we can do to bring services that will help identify issues or conditions is well needed. So thank you for bringing that to us.
Thank you, Representative Benton.
Okay, Representative Hogan. Okay, we've got all right, we've got a motion to, I think that took care of anybody that wanted to ask questions. We got a motion to pass. I have a second. Second. And does anybody want to speak on the bill? Nobody signed up. There's nobody signed up to speak on the bill. I will say that, you know, we test children at birth. And then one of the problems we're having, and just to bring attention to it, and I'm going to forget, Jamela, are you here from CHOA? Do you remember the name of the virus that many pregnant women? What is it? CMV. There is a virus now. They find that often it is so mild that mothers that are pregnant don't even know that they have it. And one of the ways that it shows that it affects the fetus is that a baby's born and has a hearing loss, and it doesn't always show up when they're tested, but it can. And if they fail the test, we have no requirement that they be tested again in a certain amount of time, and the damage goes on. Some of the major hospitals across the country are now testing for it. And then with follow-up, it is not the accepted or protocol of regular that's accepted by pediatricians all over the country. But at some point, hopefully, we will be seeing our bill about that and making sure we're getting the right kind of testing so that we can help these children vary on and prevent any further damage from their hearing loss. Hopefully, our OBGYNs will begin to talk to mothers and let them know to please tell the OBGYNs if they, have a virus and so forth. So just a little extra information about something coming down the pike that can severely, it goes from just mild no hearing loss, mild hearing loss to the total hearing loss and the need for implants that the child is going to be able to hear. So, all right. With that little extra information on
Thank
down the
you.
line, everyone in the favor of the passage of House Bill 1186, say aye.
Aye.
Anyone opposed? No. Okay, the ayes have it. Thank you very much for that
Thank
bill. All right. How about House Bill 1219?
Okay, House Bill 1219.
Let's see, and that
And
is,
this is the Senate substitute.
okay, is it LC 339012S?
Yes.
Yes, so LC 339012S, if you're working off that.
House Bill 1219 changes the composition of the Georgia Board of Dentistry, and it changes it to 17 members, 17 million. You can tell I've been wasting minutes.
We can tell you're on the budget committee.
I've been talking about billions of dollars, haven't we? This is 13 is such a little number, I couldn't say.
Oh,
It gives us 13 dentists, one member that is not a dentist or a hygienist, one that is appointed by the Board of Regents who has a knowledge of dental education of students, and 2 hygienists. 2.
2.
I think.
Oh, 2 for the total board.
Yeah. I was
2
just-
for the
I
total
was just
board.
saying
We
what the
added
total-
1.
Yeah,
Okay.
I'm just reiterating what the.
What is the total board would be?
will be
Sorry.
made out of.
Okay.
It'll be 13 dentists, 1 member who is not a hygienist and not a dentist. 1 member is appointed by the Board of Regents who has a knowledge of education of dental students, and 2 hygienists. And you can see in the bill that it tells us who can really vote on some of the things. The 2 members on the board, and all of them have to be residents of Georgia.
Okay.
And I was just going other things that were changed in the bill.
Okay.
And I'll go by line if you'd like me to.
No, thank you. Okay. Have you finished?
I'm finished.
Okay. All right. Representative Hutchinson, we already have first question. You wait? Okay. Other questions from members of the committee? Representative Petrie, do you have a question? You got okay, you just had that look on your face. You're normal. You know, this is not the last week of session when we get a little silly, but it sure feels like it. So anyway, or at least a couple of weeks before the end of session. Representative Bennett.
Thank you, Madam Chair. I don't want to delay the matter. Just curious why we are going from 11 to 17.
Well, one reason I have a problem.
Okay.
And I'd like my problem worked out. We don't have enough dentists in this state. And I hope if we broaden the thing, we'll have more access and more innovation coming in to get more dentists.
Okay.
That's my
Thank you.
problem.
Thank you.
I got some money in the budget for a dentist and to have a 501, a qualified health clinic. And I'd gotten a dentist to donate his dental equipment. And we were buying it, but we can't find a dentist. And I know if dentists are in short supply in this state. And we've got to do everything we can to promote the access to people to have quality health care. It really makes a difference in your physical health if you don't have good dental health.
Thank you. Representative Hogan.
The cost of the board,
No,
that we are going from 11 to 17.
well, it might, I don't know how much you get paid to do it. Might be about like us, do it just about for free.
Do you know what's in the budget now?
I know what's in the budget. It's a dot to the dental board, but I haven't checked into where it went to.
Okay.
The cost is going to be insignificant, Representative Hogan. There was no need for any kind of I made the decision, there was no need for any kind of a fiscal note on it.
Okay. Thank
Right.
you.
You're welcome. Representative Hutchinson again.
Sorry. Thank you. Quick question. From what I understand, the dental board has sort of an adversarial relationship with the MCG Dental School. Do we know anything about that?
With what?
I'm sorry. The dental board, from what I understand, has an adversarial relationship with MCG Dental School.
I don't think that has any relationship.
Well, if we're talking about access, from what I understand, the dental board is restricting the students from the dental school. And they're not staying in Georgia because of it.
I think
That, I mean, you're correct. We are one of 4 or 5 states that still requires that our students must take their final exam on a live individual. And during COVID, the dental students go out to, normally the dental students go out to flea markets and other places to find people willing to let the dental students work on their teeth.
This is
They
true.
couldn't find people that had enough time to go and sit until they, performed their final exam and all, and were willing to do it for them to take the exam. And they asked the board if they could have an exception because of COVID. The dental board said no. The dental board said, if you want to take your boards on a mannequin, then you can go to some other state and take your boards. When they do that, they're not allowed to come back in for a certain number of years. And as it is with medicine, dentists, once they establish a practice, they're very less likely, to move again and to come back to Georgia. So
if we-
to answer your question, and the governor overrode the board with an executive order so that our students could, as an exception, take their final exam on a mannequin. And it runs through this year also, although I think the dental board is even questioning that because the governor ordered, I'm hearing this, that the governor had one executive order that had that in it, and then another executive order that perhaps didn't repeat that. I think there's some question, I guess, in which case, I guess the governor would do another executive order.
So if the purpose, or at least one of the impetus for this is to increase the amount of dentists in Georgia, if they have an adversarial relationship, if we increase the board, will that result in less dentists staying in Georgia?
I would certainly hope that the governor appoints the members of the dental board. And I would say that the governor would be looking at their philosophy of the needs across our state and whether they thought we needed more dentists and their attitudes. And there goes the representative for the Dental Association.
Sorry.
Somebody want to get. What are you doing? Come back in here. He does not represent the dental board. He represents the Dental Association. I'm sorry. I'm just giving you a hard time. It was too good not to get you. Anyway, so does that answer your question?
I'm just bringing up the conversation.
Okay. Representative Hawkins.
Oh, I won't. If I could fly, I would fly.
Do we have any further questions? Is there anybody, did anybody sign up to speak on this bill? Anybody decide they wanted to speak on this bill and venture it out? I'm not.
Just about this subject,
About what subject?
the Georgia board.
No, I think I've covered it with Pam, if you'll let me, just go ahead. Okay, what is the will of the committee? I have a do pass. Do I have a second? Okay, everyone in favor say aye. Anyone opposed? No. Who, did somebody say no? Do I need a recorded vote? Okay, a good bill. Okay, all right. The ayes have it. Thank you very much for bringing this bill.
Thank you.
Okay. Okay. Representative Newton. House Bill 629. Okay, let me get to this. Okay, we have 9, it's LC 33. Okay, guys, House Bill and it's the LC is 339022S. LC 339022S. Is that the one you
That's
have?
what I have. Yes, ma'am.
Okay.
Thank you. Thank you, Madam Chair.
You're welcome. Go ahead. I'm sorry.
Appreciate it. Thank you very much. What you see in front of you is a much narrowed bill from one that was done earlier. We've got some able feedback from optometrists, both in the legislature and outside, other eye professionals, a lot of information, and work carefully with the chairman and other organizations to bring you what you have today, which is House Bill 629. It's really about a page long. It's much narrowed, but it's still a very pro-patient, pro-consumer bill. And let me tell you why I think that's true. I think what it does is advance telehealth options for patients. I know this chairman right here, along with this entire committee and the House of Representatives, have led on some of the telehealth expansions that have been available. I think a first in the nation last year on an expansion in telehealth. Obviously, we all saw why telehealth seemed to be so important during COVID, when there was the reluctance, just like with the patients you mentioned, reluctant to have an in-person exam. Patients were reluctant to go to their providers even when they needed it. They wanted additional options. People's lifestyles have changed. As a matter of fact, in our rural areas as well, the transportation challenges they began to see for the first time. And once again, this didn't matter if it was their cardiologist, a neurologist, or a family doctor. They found that they liked the option that was offered by telehealth, as long as it was both safe and effective and convenient for them. So now in the last 7 years, since the initial restrictions on particular contact lenses, uncomplicated contact lens renewals, technology's changed. People's comfort level has changed. As a matter of fact, I can tell you as a provider who does telehealth, the provider's comfort with working within the standard of care has changed dramatically as well, as we really had to get used to it. Really had a baptism by fire during COVID, to where we had to figure out how to take care of people who were afraid legitimately to come to the office. So a lot has changed. Telemedicine has changed. I know in eye care, there's even new equipment out there to allow you to do retina exams. The exam that's done by a retinal specialist. I know we have a member having a retina problem right now. Those kind of things through the VA and other areas are able to do amazingly different things than they could even 2 years ago. So as we look at some of the 7-year-old restrictions, what we looked at with this bill is with the capacities and the comfort level of both patients and providers to work within the standard of care. What House Bill 629 does is it puts Georgia licensed medical doctors, physicians in ophthalmology on basically the same footing as every other specialty. It does not restrict them from practicing within the standard of care for their field. I can tell you cardiology is doing it with congestive heart failure. They're doing many more visits at home. And the technology and the practice and the patients are all getting more comfortable with it, staying within the standard of care. I can tell you in the emergency department, I work with neurologists who really manage the totality of a stroke patient or potential stroke patient's care. They do it over technology that is just dramatically different than it was 5 years ago. And it's become a very accepted standard of care. And I can tell you, I was there when we first started doing telestroke things, and it was very nerve-wracking, and nobody wanted to let any official order go until the neurologist told me what to write down, and I wrote it, and then it became an order. Now we don't do that anymore because telehealth has changed. Patients deserve it. I think patients and the providers are comfortable with the standard of care. One key thing that the current bill does that we in an earlier version had done, it doesn't touch anything related to optometry. So this does not touch optometrists. It doesn't tell them to change their ways and their comfortable ways of doing their practice. It doesn't change them at all. Like I say, all it does is let a board certified ophthalmologist or a licensed medical physician to practice within the standard of care. I hope this simplification, this one step further on offering telehealth within the standards of care by the professionals who do it, when they're comfortable with it, when the patients have gotten more comfortable with it, when the consumers want the option like they do with telehealth in many other areas. I think I look forward to hopefully favorable passage of House Bill 629 to offer this to people. I know there are many others that I believe want to speak on the bill, Chair Lady, and
I know what's in the bill.
Yes, ma'am.
But I think that maybe I may have some committee members that are confused, because are you talking about it doesn't touch ophthalmologist?
No,
Tell me,
oh, sorry.
what does the bill do?
The bill leaves Georgia's current about 7-year-old guidelines for optometrists in place. It just exempts ophthalmologists, which are typically board certified licensed physicians in Georgia practicing eye care. It exempts them from the optometry standards.
Okay, so what we have in place, which is what?
What we have in place would allow an ophthalmologist to practice within the scope of his or her practice with the standards of care that are typically guided by our specialty societies.
No,
They're overseen by the medical boards.
What law is in place? What's been in place for 7 years?
The currently ophthalmologists, in addition to optometrists, were restricted from for example, refilling uncomplicated contacts on telehealth. That was previously restricted.
Okay,
This doesn't touch the restriction that optometrists may want on themselves, but it does allow board certified ophthalmologists, if they and their specialty society say it's within the standard of care, to be able to offer this option to the patients. Once again, no provider's required to do it, no patient's required to accept it. We actually have bills that prevent an insurance company from requiring someone to use telemedicine. So it just offers an option.
okay.
Be glad to answer any questions, or we
Right.
can do that after.
We have questions. Okay. All right. Representative Beverly, you're up first.
Thank you, Chair.
Sorry.
Chair.
Go ahead.
I have several questions, but I want to get right to the point. Let me make sure, Dr. Newton, you're exempting ophthalmology from the exam process.
From the exam process that an optometrist would.
That
do.
optometrists
Correct.
should do. The exam process, as it relates to, I think you mentioned contact lenses.
Yes, sir.
The exam process, as it relates to contact lenses, requires that a doctor, optometrist, examine the corneal tissue. Is that correct?
Well, actually, when it comes to standard of care in ophthalmology, I'm not the expert. The good news is we do have one here to ask your questions
Great.
to.
The good news also is I'm an expert. This is what I do. So I'm asking a question because I want to make sure that the general public understands the line of questioning that I have. Okay. Corneal, when someone puts a contact lens on their eye, the cornea becomes hypoxic, which means it starves of oxygen, correct? Any avascular organ, if you cover it up, is going to starve of oxygen. Skin, hair, it's going to starve of oxygen. When it starves of oxygen, that tissue becomes hypoxic, which means it starts to go into, we talked about this before, things happen when tissue becomes hypoxic, including it swells, it starts to die, sepsis can come. And in the cornea, you have to evaluate that. If you put a contact lens on the eye, you're blocking all the oxygen gets to the eye. How do you tell, just general public, and I hope the expert will come up and talk about this. How can you tell through a telemedicine exam that the cornea has become hypoxic? Because that's important in the long-term strategy of managing disease. Taking a picture of the cornea cannot tell if it's dying, but an eye exam that a doctor can actually look at with a slit lamp will give you an opportunity to see what those layers look like. How do you do that in a telemedicine exam?
Well, the great news is I don't, but I have people who do it safely. I've been told it's done safely in 47 other states. I am not the expert on eyes. We do a certain amount of, I do telemedicine. I've done ear infections, asthma treatments. There's a lot of things we can do. I actually would be more of an expert in more episodic care or emergency care. But when it comes to the eye care, I would appreciate it if you'd direct the questions to an ophthalmologist who understands her standard of care definitely more than I do. And so I apologize for not, but I'm not claiming to be an eye expert.
No,
I take metal out of people's eyes and things like that, but
right. No, that's all the questions I have for now. I'll wait for the expert to come and we can have a conversation. Thank you, Dr. Newton.
Do you have an ophthalmologist?
Either by Zoom or in person, I've been told.
Okay. Come on up and you can.
Well, can I?
No, you stay where you are. I'll put the ophthalmologist up here where you are. You don't get out this easy.
Go ahead. No,
Do you want to
that's fine right there. It's fine.
if you'll respond to Dr. Beverly, who is an optometrist, and respond to his question or statement.
Okay, well, let me just start. My name is Dr. Kelly Crook. I'm a board certified ophthalmologist. I am licensed in 17 states, including Georgia, where I currently reside on St. Simon's Island. I have worked for several different telemedicine ophthalmology companies since 2018, and I have reviewed over 130,000 exams. Okay. So what you're asking is, as you're an optometrist. Okay. So as an optometrist, when you give a contact lens prescription, you give that patient a prescription for a year with no additional oversight unless they have an issue. You give them that prescription for a year. You would, according to the AOA, you're typically viewing contact lenses as a risk factor. Okay, so your board instructs you to see a patient annually to assess the hypoxia of the cornea. Okay, now I am not suggesting during these exams that you change your practice guidelines by any means, but as an ophthalmologist, our boards, what could be considered the closest of a standard of care for us, an outline of a standard of care, is the American Academy of Ophthalmology's preferred practice guidelines, which talks about the intervals of a comprehensive exam for a patient. Okay, now those intervals, there is for contact lens checkups, those would be considered interim exams between those intervals. Now, these contact lens renewal services, these contact lens renewal exams would be meeting the standard, if not exceeding the standard, for an interim exam for our board, for the American Academy of Ophthalmology. Now, if I have a patient that comes in who was seen in person a year ago for their comprehensive exam, and that doctor is an optometrist who says, you know what, after seeing you, I believe you should be seen in a year because I want to check how your cornea is doing with hypoxia. Okay, I am all for that. I am in no way saying that your practice should be changed on any level, and I am all for those patients having not only the option of doing these contact lens renewals online, but also doing, because they are separate exams, doing a comprehensive exam with you, because you are the expert on this patient because you had just seen them in person. So I'm not saying not to check in, not to, if you are more comfortable and your years of practice says to you, what I'm seeing in this patient, they should be seen annually for a comprehensive exam, I'm all for it. That shouldn't exclude them from also having these interim exams.
So what you're saying is that that for optometrists, their association may have put one standard of how often they should see a patient that wears contacts or the contacts lens, and the ophthalmologist and their association and board of standards may have another.
Yes,
And they're
they do.
Okay,
They 100% do.
thank you. We may ask questions again. Let me go. Representative Petrie.
Thank you, Madam Chair. And I actually pushed my button earlier, but I may have a question for the doctor while she's there
Okay.
and for my good friend, Dr. Newton. But so the Board of Ophthalmologists supports this measure. Where do they stand in terms of this measure in the state of Georgia?
I can't comment on the state of Georgia, but they have mentioned
Then in that case,
No,
I'll go to
just the state
Dr.
of Georgia.
Okay, so let me go to Dr. Newton then with that question. And then I want to know if the optometrists are represented here, and I believe they are. I want to understand from them, Dr. Newton, now that you've carved them out, which you've done, I want to know, I'd like to hear from them and understand where they stand on the measure as well. Thank you.
My understanding, and I believe they're here, is that this current version, worked with the chair lady, has been supported by MAG, is supported by the Georgia Society of Ophthalmologists under the American Association of Ophthalmology guidelines. So I've been told that they're supportive of it, and I know they're here, that they may speak to that directly if they need to.
And I can verify that they have worked, I was on the phone call. They have worked with us and the Georgia Society of Ophthalmology in accordance with the American Academy of Ophthalmologists they've worked to narrow this bill. And I really appreciate the fact that they have reviewed it and worked with us, and they are in favor of the way it is now.
So Madam Chair, again, because the discussion is about, quality of care.
Right.
So the ophthalmologists endorse this as safe and
Yes.
best practice, if
I
you
guess-
use that term, the ophthalmologist, and then we'll hear from the optometrist in a moment, correct? Is
I
that,
would-
is that accurate?
I don't know that they're endorsing it. I think that they have narrowed the bill to where they are okay with the bill. And
I believe they expressed support of the bill.
right, is the way they've narrowed it
If we
down
could hear
now.
from them, that'd be helpful.
Right, here come Bethany
Okay, thank you.
and
Thank you, Madam Chair. Dr. Newton, I'm Travis Lindley. I'm the Executive Director for the Georgia Society of Ophthalmology. And as the Chair and Dr. Newton have alluded, we appreciate them working with us. It was not our bill, as my friends in optometry know, but it is in keeping with AAO policy. So we are here, as is Ms. Shear with the Medical Association.
And I would say that from the standpoint that we've worked through this bill, appreciate the work that you've done with us, and speaking with our physicians, they have not expressed safety concerns with the bill as it stands.
Representative Peter, I didn't mean to be misleading, but endorsement was where I got tangled up on a difference of actually endorsing them or just being, okay, thank you. Okay, Representative Jaspers.
Thank you, Madam Chairman. This, I would like to echo Chairman Petrie. I'm hearing from the optometrist, but mine's a practical question. I mean, when I see my optometrist, and I go to both, I think the first visit is very important. And just me looking at this, you're looking at lines 22 through 25. I'm not sure that it requires that. And that in-person first visit is done. And which, leads me to, those first visits you make with these professionals, they really kind of go over the risk that are out there. If you do this, you do that. And I just appreciate that in-person dialogue. But my question, does this prohibit or get around that first visit?
I believe that, and the ophthalmologist can speak to what her standard of care is in this. I can tell you with every era of telemedicine, some providers are comfortable and some never want to do any telemedicine. And the same's true with some patients. And I'm talking about in cardiology and other fields. Some are well-versed, they have the right equipment, they have the right expertise and the training, and they're very comfortable with it. Other situations that wouldn't be true, but this body doesn't try to keep up with neurology and nephrology and cardiology or to try to determine what the standard of care are. Those are changing as people get more comfortable, as the equipment gets better or changes, as patients get more comfortable. That's a little of the challenge in this, is that, and I guess the ophthalmologist can speak to the initial exam and whether what the current standards or requirements are in ophthalmology.
Well, I can make this a lot simpler. It doesn't get rid of that first exam. Okay, so they need to have had a comprehensive exam where they were prescribed a contact lens, they were fit for a contact lens, and only then do we see them for a renewal. This is not replacing that initial where they discussed how to care for your contacts and whether you're a good candidate for it. These are people who were tolerating contacts for a good year, at least, before we are seeing them.
The law representing Jaspers, but it's in the medical board rules about first visits and telemedicine and
Yes,
all.
ma'am. Well, that's what I figured that the back page referred to. But I do, as Chairman Petrie said, the optometrist, this is really affecting them, and I'd love to hear from them too.
Representative Bennett.
Thank you, Madam Chair. On line 13. Thank you, Mr. Chairman Newton. You entered your explanation. I'm not an optometrist and I'm not the expert, so I just read what's before me. And you started talking about ophthalmology, but there's nothing in here until you cross out ophthalmologist on line 20. I'm always concerned about scope of practice. And so, first of all, on line 13, eye examination means an in-person assessment, which includes telemedicine. In-person and telemedicine, to me, are not the same, although I welcome telemedicine. So that's one question, and to clarify that. And then I'd like to know what the optometrists say, since this seems to be pertaining to them. Is this more restrictive to an ophthalmologist, giving optometrists more freedom to expand their practice, or how does this relate, ophthalmology versus optometrists, and how does this impact both of their scopes of practice?
Thank you for that. I think the line 13, I know we worked carefully with Legislative Counsel to make sure that we did not adjust the practice of optometry. We only changed things that affected the practice of ophthalmology, the licensed medical doctors who practice ophthalmology. So we didn't, by putting that in there, it made it clear who was doing under the code section that existed with a lot of detail about the 2015 standard of care in optometry. This was just to ensure that nothing in the bill would change what the optometrist held themselves to as a Georgia code standard, written standard of care. I believe that's the reason that line, that those 3 words by an optometrist were placed in there.
It's the in-person versus the telemedicine the in-person versus telemedicine. Is telemedicine now being expanded to mean in-person? In-person.
I'm sorry, where is it you're reading from? I guess I'm sorry.
Dr. Beverly, what are the rules from your board regarding the first visit? Is there rules to it, sir?
Yeah, so I think the society is here, and one of our attorneys here, he'll go into that with the questions you guys may have. Okay.
I think I could possibly address this, and you could tell me if I'm wrong on this. But for the in-person, one of the platforms that I do work with does telemedicine in Georgia. I'm not a part of it, but they're able to do it in Georgia because they have an in-person portion of their exam. So that means the patient presents themselves to a clinic in the state of Georgia and are seen either via live feed with the doctor or via a store and forward kind of design, but the patient is in person in a clinic in Georgia or a hospital in Georgia. I don't know if I'm overreaching.
Does that apply, as far as you know, that could be an optometrist or an ophthalmologist?
Yes.
Is that correct?
Yes, there's
Okay.
both
So they
optometrists
both
and
can do it,
ophthalmologists.
but
Yes.
it's only from a physician's office or clinic?
Yes, you have to be, according to the previous law, the way I was reading it
you're right.
is you have to present yourself. So like the diabetic retinopathy exams at the VA here in Atlanta, the patient has to present to the VA hospital to get the imaging done there.
I believe that
and-
was an earlier version of telemedicine laws that required them to originate at a physician's office, a clinic, or a hospital only. It was kind of, the original thing was consulting specialists were the only ones who would do telemedicine. So you had to already be in a physician's office to see another physician by telemedicine. Those have been updated a couple of times by this group already.
But Bethany, can you come back, please? In the telemedicine bill, isn't there still emphasis on that first visit?
Yeah.
And in establishing,
So I think longstanding rules with the Composite Medical Board set out kind of what Georgia views as the rules for providing care via telemedicine. And what that rule essentially says is that the only way to establish a physician-patient relationship and to see somebody without an in-person visit first is essentially either A, that patient has come from another physician. So, there's a physician that essentially has looked at that patient first and they're referring you to them. B, you can complete the visit with the same technology or peripherals that make the visits equal. So in the practice of ophthalmology, that would require the patient to have equipment with them that just doesn't exist in the home space at this point in time. And then once you get past that point, so once you've kind of made it past that point, the standard of care is the same. So if you're providing care via telemedicine, if you're providing, if a physician is providing care via telemedicine, their standard of care is the same if they're in person or if they're on telemedicine. So if they can't do what they need to do to meet the standard of care via telemedicine, they can't complete the visit. So the board views that as if you try to do a visit where something would be required to be done that you cannot do via telemedicine in order to meet your standard of care, then you would have to bring that patient into your office or into someone's office so that that can be completed. Hopefully that helps.
So that
clear.
would be like a pregnant woman in our public health departments. If they had the equipment to do a sonogram, then you could have the physician in an office in Atlanta, and you could have a nurse with a pregnant woman in a public health office in Waycross, Georgia. And if they had the machines, which they do now have, that can do sonograms and transmit it back and all that, then that would qualify.
And we see this a lot in like school-based health centers where they may have a nurse that has the equipment and is helping to see those patients, so that not necessarily in ophthalmology, but in other types of medical practice, this happens in kind of school-based systems or other things where you have a nurse that's helping to kind of get that care into places where they don't typically have the access.
Well, I just had an eye exam last Friday, sometime last week. Is that equipment it's not available for the person. So basically, as far as the ophthalmologist, the MDs, they would have to have that first visit with patients in their office.
And I
or
understand
somebody's office with equipment.
from the way their standard of care works, they would have to have an in-person visit every so often because of the way that it was just described, that they say that you need this complete eye exam every so many years, probably depending on the age of the patient and all of those things, risk factors, et cetera, that would require them to bring that patient into the office in accordance with their standard of care.
Okay. All right. Representative Jaspers.
Thank you, Bethany. It's really for you.
Yeah.
It just, I was going to chase the rabbit. I was trying to get my hands around this. So it's on the standard of care. So if an optometrist, you said they had to have the equipment. So could this be the equipment to allow not that first visit? If I had to have an iPhone 10 or 11 or a 5, I mean, remember us having this committee, we had this conversation a couple of years ago, I remember.
Yes, not as it stands now, not with the technology that we have right now. I mean, we're talking significant advancements because my understanding is that there are certain measurements and things that need to be taken during that first visit that you would not be able to do with the technology we have available to us over the phone.
I mean, Representative Jester, think about it. If you've had one anytime soon, they would not be able to check the pressure.
Oh, yeah.
And I remember the little machine that comes up.
Absolutely. I
touches
guess,
your eyes.
Madam
Yeah.
Chairman, I'm looking at the visit 2 and 3. We're talking about where this does become the standard that people use to measure. And I'm having to wait 3 months to get I don't get to see my ophthalmologist till April.
Okay.
Yeah.
Are you all right?
We'll see. We'll see.
If you're not, I think I can probably help you get in sooner.
Yes, I think that it's really important to remember that part of the reason that we have traditionally left regulation of the practice of telemedicine as kind of a discussion at a board level, is because as technology changes, the board is continually assessing that. Having said that, in all of my work on telemedicine through the medical board and the legislature, their commitment to the standard of care being the same for both has never wavered. Even during the pandemic, that was a constant discussion that we needed to try to make sure that that standard of care was the same.
Thank you.
Representative Douglas is on Zoom. Hey, Demetrius.
Madam Chair, how are you?
Hi. Oh, you're
Committee-
over in the chamber.
No, that's.
Yes, I am.
Are you getting lazy and just not coming over to our meeting?
No, I had another meeting. I just wanted to chime in on this and get some clarity for from the dentist here and the author of the bill. I have kids in college that have to get their exams every year, and this has really helped with renewing those. They have contacts now. So for a year, is that extended? I know they have to go in the office. How many years can they go without having to come in and see ophthalmologists or going to get their exam in-house? How long does this last?
Go ahead. Go ahead.
After the initial visit, I know that.
Realistically.
Go
No,
ahead.
go on. So, of course, it kind of depends on the practitioner they've seen is what I will say. But as an ophthalmologist, if they were seeing an ophthalmologist before, the standard of care is the preferred practice guidelines that set out certain timing by age. So we recognize that as people get older, that there are more problems that can spring up, and then you need more frequent comprehensive exams. So college age would be 5 to 10 years. Now, these contact lens renewal services, the criteria for how often they do these exams, the major one that I work with is 4 years. They only allow them to do it for 4 years, so that you're at least meeting that range.
Does it depend on their risk factors like diabetes and hypertension? Would they be
They are not
excluded?
at all seen if they have, so
Okay.
there are past medical history and medical history questions. If the patient answers yes to any of those questions, they are automatically diverted from continuing the exam, and they are instructed to see their local doctor. They will not be allowed to renew on these platforms. Those questions include diabetes, macular degeneration, glaucoma, any hereditary diseases, if they've ever been diagnosed with any of those. There are also symptom questions that the patient gets, heavily weighted towards dry eyes, but they are symptom questions that the patient has to respond to. If they answer yes to any of those, they are also not able to continue their exams.
Thank you very much.
Sure.
Thank you. Bye. Representative
that.
Mitchell.
Okay. Dr. Newton or Dr. Crook, essentially this would have become law. With this, it would simply allow online eye exams by ophthalmologists in another state or another country for that matter, not even be requiring it to be done in real time. Is that accurate to say?
They're Georgia licensed.
Yes.
Doctor, all these are, the only way to do telemedicine in Georgia is have a Georgia license.
Mhm.
So
So they could do this from another state or another country, in fact, if they're licensed in Georgia.
as long as they have a Georgia Medical Board license, correct.
Thank you, Madam Chair.
Okay, Representative Hutchinson.
Your computer.
I just want to make sure I understand. It sounded to me from the medical organizations that they can live with it, but they're not super excited about it. I won't put you on the spot.
They're not taking the lead on it.
Okay.
That's
Okay. All right. Thank you.
They see nothing, I think I can say, they see nothing that they think puts patients in danger as long as the ophthalmologist is following the standard of care.
So just what's going in my brain is why aren't they excited about it?
But, okay,
That's just a conversation, not a question, rhetorical.
I think at least I think the question is, okay, so what the bill does is that, is it my understanding that, Dr. Beverly, do the optometrists want to keep the rules like they are for y'all, or like in what it is? And yet the optometrists are following what they've always been able to practice.
What I think would be helpful, Chair, is if the Optometric Association folks get up and.
Can you, which ones are they? I've got a whole list of people.
If you don't mind, Aubrey DeLines go and then the president of the Georgia Optometric Association.
Madam Chair, the president defers to me and the rest of the optometrists will on this issue.
Okay, okay.
Madam Chair, members of the committee, I'm Aubrey Valens. I'm the general counsel for the Georgia Optometric Association. And first, I'd like to see a copy of the committee substitute, which I have not been provided. And I would, with the utmost respect to Dr. Newton met with us about the original bill last year. 1-800-CONTACTS, 1-800-UTAH has never met with us about this bill. There's never been any discussion with them. And even as we come to this committee, so nothing's been worked out. And I thank you for letting me see this copy.
Okay.
If you give me 30 seconds, I can tell you what the difference is.
Okay.
If you would refer back to your original bill, and I'm going to talk about law, not about rules, and law supersedes rules. I'm a lawyer.
But that's not what I want to know.
Yes,
Aubrey.
ma'am.
Right at the moment, I want to know, it looks to me that it lets, ophthalmologists have been able to do this, but optometrists have had it where you had to have the exam. They have they have not been able to do it by telemedicine. So
That's not correct, Madam Chair. I'm sure in hearing their testimony, that's what you would think. That's why I want to look, if you would look at the original bill, which is the law.
we don't have the original
Well, the
bill.
law for telemedicine
all right.
said eye examinations mean an in-person assessment, which includes telemedicine at a physician's office or an optometrist's office. You heard this is an optometry bill.
Okay.
No, this was a physician's and optometrist law regarding contact lenses and glasses. It was both, and I'm going to read it again. Telemedicine at a physician's office or optometrist's office. You've now struck physicians. I don't know if physicians can do it or only ophthalmologists, and you've replaced it with the word ophthalmologist. Whether that has any legal impact, I'm not going to conjecture at this point. But what you have done is you have required an in-person assessment by an optometrist. I'm looking at the substitute now, but looking down on line 15, you've struck the in-person for the ophthalmologist. Now, whether you call that lower quality or a different standard, but you struck the in-person for the ophthalmologist. So you say optometrists have to do this in person. Ophthalmologists don't have to do it in person. They can rely on a patient who can come in there and do a checklist and had eye diseases and glaucoma and eye injuries and diabetes and everything in the world, just check no. There's no one to check that up. There's not a machine to look at their eye and see if they're lying or not. They're totally dependent upon the patient to see if they're telling the truth. You heard also that this is left up to the boards regarding standard of care, whether it be 12, that's not true. The law states, I'm not going to deal with rules, I'm going to deal with the law. The law states, and I'll read it to you, explicitly states an expiration date of not more than 12 months from the date. That's not the optometry rule. That's not the ophthalmologist rule. That's the state law of Georgia. It's right there. And you know what is most concerning about me? You, Madam Chair, took the lead, and I commend you for that. And we spoke in favor of House Bill 307, the platinum standard for telemedicine.
Right.
And we spoke, and right, the first thing it says, real time. This is not real time. They can take that form and look at it a week or 2 weeks later. You're changing your own telemedicine standard. I have copies of that law if you'd like to have it. You'll pass that out. It says real time and goes on to say, facilitate the assessment, diagnosis, consultation, treatment, education, care management, and self-management of a patient's health. That's not in this. This is just refraction. But again, you took the lead and I commend you. And I stood over in the Senate and spoke in favor of it, real time. Put real time in front of the assessment or put in person in front of it and see if they like it. You're changing the standard of telemedicine. We've seen this.
This
back-
is not, Aubrey, this is not my bill.
I know it's not.
So
I know
no,
it's
and
not.
I'm not
I know
changing
it's
the
not, Madam
standard.
Chair.
Can I make that
And-
perfectly clear?
And I know, I commend you for taking the lead in telemedicine, but I just want to point out that the gold platinum standard you wrote says real time. This is not real time. Again, you've heard about what the Ophthalmology Society said. Let me read this. The public should understand that these online tests can measure the power of your eyeglasses prescription, but they can't detect eye diseases that others have hidden symptoms, said Michael X. Rapka, medical doctor of the director of medical affairs for the American Academy of Ophthalmology. Never use home vision tests to order contacts. This is right off the Academy of Ophthalmologists website. Give a copy of it. I'm not making this up. They're doing this back and forth because they want to say, well, we really don't endorse it, but we really think it's like right off the own American Academy of Ophthalmologists. Don't do this. This is a bad idea. Anyway, maybe we will be able to meet with them in the interim, but we ask you to oppose this bill. We've got lots of groups that have signed things, Johnson & Johnson and others that don't like it, but I'll be happy to answer any questions anyone may have, but I'm dealing with the law, not the rules. And the law is 12 months. It's not about a rule for a board.
Well, all I've got to say about this
Yes, ma'am.
is I don't wear contact lenses. I have never worn them. And I am really glad that I don't wear contact lenses. I'd lose them, first of all.
Well, we appreciate
and
your
it's like
leadership
that, and I'd
in
stick them in the wrong place
telemedicine.
in my eye. Okay, we have some questions. Representative Fry is on Zoom.
Thank you, Madam Chair. I'm sorry for the background noises. I think there's a question that I'd like to pose. First off, I do wear contacts, and I remember when that law was instituted, it aggravated me, but I did understand that it probably had some reasoning behind it. I've never had a personal complication with my eyes and my contacts, but what I'd like to know, if I heard the chair correctly when he said there were 47 other states that do this, and so we should have the data in hand of the increase in eye issues within those states. And I'm sure it just didn't happen last year. So is there anyone can address the question of actually, if we have a model of 47 other states that do this, is it actually causing a problem? And what are those statistics? Or is this all conjecture?
We haven't seen 47 other states' law. We've got a letter here that says 14 states prohibited. I think without seeing all the every one of the laws in every state and seeing if they're identical or close to, I don't think I would admit to that. And I don't think there are 47 states that do it. Maybe they can bring me those laws and see if they're identical though.
We have the other doctor that wants to comment on that.
I'll yield to the doctor.
Thank you.
There are 37 states that do it, not 47. There's 37. The American Academy of Ophthalmology had commented on online refractive exams with a letter to the Board of Washington.
State.
Yep, Washington State, saying that these are very low risk. So they have formally commented on these exams. And what you're mentioning for 12 months, for 12 months, that's how long a contact lens prescription is good for. That has no bearing whatsoever on how often a patient should have a comprehensive exam. So the prescription is good for 12 months. If you are seeing let's say a doctor of optometry, that would also coincide on maybe what they were deeming was necessary for your comprehensive exam as well. But that is not necessarily what we follow as ophthalmologists.
I can tell you, Madam Chair, that if the one of the challenges is having a single specialty where the legislature tries to determine the standard of care. And as we've seen, it is evolving, both patients' comfort as well as providers. Once again, there is no Georgia state law to hold up and say, this is how quickly you need to see a congestive heart failure patient, Mr. Cardiologist or Miss Cardiologist. This body doesn't get into the standard of care for other specialties. I'm not sure how this happened 7 years ago that it did, but I'm not sure we have the expertise more than the American Ophthalmology Society to decide what this acceptable standard of care is. That's what kind of surprises me about the bill, the original bill 7 years ago.
Right. Bethany, I don't think that MDs have a scope of practice. Am I correct? There's not on MDs, I don't think.
That is correct.
They don't have a scope of
As long as they're
practice.
licensed, they can perform medical acts.
Right, they can form medical acts. So that, is a wider thing
Within the
than,
standard.
pardon?
Obviously within the standard.
Well, right, within the standard of care. Okay, so that,
And there's plenty of people overseeing us when we do that, including the medical board, the specialty societies, hospital medical staff, even plaintiff lawyers. If there was any damage, my understanding is 37 other states haven't been seeing damage due to letting the ophthalmologist practice under an ophthalmology standard of care.
okay, I have a whole, Aubrey, is this whole list of people on Zoom, are they the optometrist?
No, Your Honor. No.
Your Honor.
No, Madam Chair, you're not.
Woo! I get to play,
I'm sorry, I get in my plaintiff's lawyer mode very quickly, so.
I was already feeling that already anyway, so I wish I could be the judge on one of your cases sometime. So.
Maybe one day.
No. I almost went to law school, but I got smart. So, okay. Toby West, are you from out of town? I mean, from out of state?
I'm from Georgia.
From Georgia? Okay, all right. Briefly, I'm gonna go down this list and see. All right.
I will be very brief. I don't know how I'm going to follow that, but my name is Tony West. I'm the Deputy State Director for Americans for Prosperity, Georgia. In general, we support telemedicine. We support the expansion of options for consumers so they have greater access and hopefully leading to lower costs for the services they need. We support House Bill 629 because we think it will accomplish these goals. We think it's pro-consumer, it's pro-innovation. I think it's very appropriate for the General Assembly to look at our laws and our regulations to ensure that it isn't inhibiting new technology and emerging technology that will help patients long-term. So we happily support this bill and encourage this committee to do so as well. Thank you.
We have a lot of people online. Are the people online Kane, Ariel Kane, Benjamin, and I can't pronounce the last name, Gerard, Courtney Jocelyn? Are y'all in favor of the bill, against the bill? What are you local so that if we continue our discussion, if you're online?
Hi, Chairman. I'm Ariel Kane, and I'm in Washington, D.C. I'm in favor of the bill. I have my testimony if you would like me to give it.
Is it? I don't think so at this point. I think we may be back with everybody online at another time.
Okay.
Who does she represent?
Representative Beverly.
Who does she represent?
Who do you represent?
I'm a health policy researcher. I work at the Progressive Policy Institute in Washington, D.C.
Okay. And you would be able to join us again by Zoom?
Yes, by Zoom, it's no problem.
I have a feeling that I'm going to get a motion to table this bill.
Got it.
I mean, I'm feeling it. Representative Beverly.
Thank you, Madam Chair. You have such amazing wisdom to realize that I'm going to move. Yes, and intuition to move due table.
Okay, I have a motion and a second to table. Is there any discussion about the motion? All right, then we're going to have to do this by hand. Everyone in favor of the motion to put this bill on the table, raise your hand. Okay, everybody, I think that got everybody. So anyone opposed? Anybody online of our members that are opposed, or is everybody for it? All right, the ayes have it. The bill is on the table. Wait a minute. If I would like for the people that are involved in this bill to get together and discuss this. And you can include me, or you can come to me once you've worked something out or not work something out. Okay. And then I can decide what to do going further. Okay, with that, we are adjourned. Thank you to the committee.